slip capital femoral epiphysis, another important topic in the hip. So this is not a very commonly coming case, but case in this definitely they will keep this, and there will be a lot of discussion because diagnosis will not be very difficult. So there will be a lot of discussion on slip capital femoral epiphysis because you will not have too many points to give a differential diagnosis or anything. So straight away there you can give a diagnosis very easily. So slip capital femoral epiphysis, as you know, has got multiple names. So these are the various synonyms by which the slip capital femoral epiphysis is called. The names are self-explanatory. So it is an adolescent coxa because slip capital epiphysis is common in the adolescent age group, usually in the 10 to 15 or 10 to 20 age group. That is the most common at the time of the growth spurt. And it is also called the epiphyseal coxa because the coxa occurs at the epiphyseal area. And there's a epiphysiolisthesis. That's what spondylolisthesis, because there's a slip of the epiphysis called epiphysiolisthesis. And epiphysiolysis, sometimes it also can be called as epiphysiolysis. It is nothing but the scoop of ice cream. If you imagine you take a scoop of ice cream, the scoop just slips off from the cone. So that's how it has been described, the slip capital femoral epiphysis, like a scoop of ice cream slipping on top of a cone. So obviously the history, and it was to great surprise, it was described in 1572 by a person called Pare. It was so early in this age group. I mean, 1572, so somebody has described slip capital femoral epiphysis. And Muller in 1889, he coined a the term which you cannot even spell it out. So it is a German term meaning bending of the femoral neck in adolescence. So when Whitman created the first osteotomy, he did it in 1909. And of course, Boyd was the first one to fix the slip capital femoral epiphysis with pins. So this is short history of the slip capital femoral epiphysis. Maybe you can remember one or two names like Boyd, who just first pinned it, and Whitman, who done the first osteotomy. So by definition, obviously the definition is slip capital femoral epiphysis means the capital femoral epiphysis is displaced from the metaphysis through the physeal plate. So this is the actual definition, but obviously it is a misnomer. Normally the head, everybody thinks the capital epiphysis slips, but on the contrary, the capital epiphysis does not slip. It is only the metaphysis, or the shaft that is along with the metaphysis, that is displaced antero-superiorly. And obviously the head also will be pushed posteriorly and inferiorly. So head actually is inside the acetabulum. If it's going to slip, it's going to go outside the acetabulum. But here the head is definitely inside the acetabulum, whereas the shaft with its metaphysis, that only starts slipping and push the head posteriorly and inferiorly. So it's basically the slip capital femoral epiphysis is only a misnomer. So what happens to the Patho anatomy? So that's what I told you already. The femoral head is in contact with the acetabulum. The femoral shaft and the neck rotates externally and catallate. So it rotates outward and it rotates proximally. So obviously the head starts moving posteriorly and inferiorly. So this is the basic Patho anatomy of the slip capital femoral epiphysis. So we'll come later as to why this happens. So what is the reason why this happens? So basically this is actually what is happening. So why it happens is, some will be explained later. So the incidence, obviously there are a lot of the different books give different incidences, and as per TACJAN is around 2 per 100,000 population. So 1 lakh population, there is around 2. And some books say it is even 7 because it depends upon the population that they're looking at. The African population seems to have more incidence, and so the Hispanics and the American population seems to have lesser incidence. So 2 per 100,000 population is an average from the books. And of course, the age is adolescent males and boys around 14 years, and the girls normally they're present around 12 years. So left is having a greater incidence than the right. The reason why is because most of the children are right-handed. So when you start writing right-handed, your left hip is given more, it is pressed against whatever the chair you're sitting, because you give more pressure on the left hip. So they say that may be the reason why left side seems to be more common than the right side. And of course, there is a huge variation in the presentation, whether it is bilateral or unilateral. On average, they say, few books say it is 25%. So it is around 18 to 25%. I've written 80% because some books say 80%. So don't say in the exam it is 80%. It's around 25% is the incidence of bilateral slip capital femoral epiphysis. And of course, it's the two types based on the etiology. I'll first come to the atypical ones. The atypical ones are the one which is associated with endocrine disorders like hypothyroidism, hypopituitarism, CRF. CRF is chronic renal failure. Patient usually have a hyperparathyroidism that will also cause slipped capital femoral epiphysis and irradiation, of course. The endocrine disorders and chronic renal failure usually will present bilateral. So you are sure that most of the time, and definitely the opposite hip also has to be given some form of treatment. Whereas in trauma, some of the other mechanical factors like only obesity, growth spurt, puberty, all these things usually present unilaterally. So atypical with endocrine disorder and chronic renal failure usually are bilateral, whereas the idiopathic ones where you don't exactly find out a cause or endocrine cause, then those things are generally unilateral. So what happens is, so we will go into the etiopathogenesis of what exactly happens. So in majority of cases, it is not proved. Okay, it is not proved why the slipped capital femoral epiphysis occurs. But as per the mechanical factors, you just look into these three important factors which can be considered as a mechanical factor why the slipped capital femoral epiphysis occurs. So for the slip to occur, the perichondrial ring complex called the perichondrial ring complex, I'll come to that later, what it is. There is a thinning of the perichondrial ring complex. Actually, the perichondrial ring complex has got multiple collagen fibers which are arranged in vertical, horizontal, and oblique planes. So these collagen structures are low. The collagen content of the perichondrial ring sometimes becomes very low, and that thins out the perichondrial ring complex, which is some kind of a protection for the slipped capital femoral epiphysis. The perichondrial ring complex, it's enclosed. I'll come to the next slide. What is perichondrial ring complex? Then there's retroversion of the femoral leg. In almost all the cases, because normally we have an antiversion, in almost all the cases of slipped capital femoral epiphysis, they've seen there is a retroversion. There is a severe retroversion in some cases, and the femoral capital epiphysis is oblique plane. Normally it is horizontal, so it does not slip out. But when it becomes oblique, then as always the shear forces are going to be very high, and it is going to slip out. So on most of the time, when you see the slipped capital femoral epiphysis, suppose it is unilateral, what happens is it is 11 degrees more than the normal side, the obliquity of the femoral capital epiphysis. And when one is more affected and one is lesser affected, it is always seen that the more affected seems to be more oblique, and on average it is 5 degrees more than the affected side. So that starts slipping out first, and then the next starts. So the obliquity is a very important phenomenon, important reason why there is a slip of these capital femoral epiphysis. So the perichondrial ring complex gets thinned out, the femoral neck gets retroverted, and there is a obliquity of the femoral capital epiphysis. So what is this perichondrial ring complex? So we'll just go next. What is the perichondrial ring complex? So it is a fibrous band that spans the physeal plate, and it extends from, we know the physis is almost sandwiched between the metaphysis and the epiphysis. So this is kind of a physis from the metaphysis through the epiphysis, covering the physis, the perichondrial ring complex. So it is, as I mentioned already, the strength is provided by the collagen fibers. When the person becomes older, there is a mammillary process. So what happens is interdigitations between the physis and the metaphysis. So this interdigitations along with the perichondrial complex kind of covers the physis and prevents it from slipping. So the forces required are within physiological range normally. Normally, the perichondrial ring complex can easily counteract the physiological forces. Even if you are obese, it can normally counteract the physiological forces needed to slip the femoral capital epiphysis. But some cases where the collagen fibers are low, the strength of the collagen is less, and the orientation, the spatial orientation also, as I mentioned, the collagen fibers are almost in 3 different planes. When the spatial orientation of these collagen fibers are disturbed, then the person ends up in a slipped capital femoral epiphysis. So this perichondrial ring complex is associated with other conditions like blanch disease, both infantile and juvenile. So both these conditions here also, the perichondrial ring complex seems to be weak. So that is why there is a, the angulation which occurs in the blanch disease, they say it is also of a similar etiology like the slipped capital femoral. There it does not slip, it angulates, but here completely it slips. So the similarity of the blanch disease has been proved that the perichondrial ring complex is one of the most common mechanical factor which causes the slipped capital femoral epiphysis. So when we go into the physis, the next important thing is the physis. I think everybody needs to know the anatomy, because slip capital femoral epiphysis, if it comes as an essay or a short note, or almost the physis alone can come as a short note for you in anatomy. It can come in your general papers. So make sure that you all are very thorough with the anatomy of the physis. So in the physis is, it is sandwiched between the metaphysis and the epiphysis. So on the epiphyseal side, from the epiphyseal side above downwards, we will go. So what it's called is a germinal zone, or the it is the germinal zone of the resting layer. This is the resting zone of the germinal layer, and the vascularity comes from here. And next is the proliferative zone. So from the next is the proliferative zone, where you can see a lot of chondrocytes. It starts proliferating. And next is the hypertrophic zone. So our area of interest is the hypertrophic zone, which most often the theories say the problem rests with the hypertrophic zone, and of course also in the proliferative zone. So it is, most books say the problem is in hypertrophic zone, but we go into detail because I just went into a lot of referrals. So what exactly happens in slip capital femoral epiphysis, the endocrinal reasons why the slip capital femoral epiphysis occurs. In all the books, even physiology books, mention that the problem happens both in the hypertrophic and the proliferative zone. But to be very on the safer zone, the PGs can say it happens in the hypertrophic zone, because you will not be punished if you say it is in the hypertrophic zone, and you can maybe add on to say it is also in the proliferative zone. So the next is the area just below the hypertrophic zone is the area of the endochondral ossification. So the initial ossification starts here. So this is how the anatomy of the physis goes. I think this is a very simple diagram. Don't complicate it too much. And this is what normally happens. So what are the so what happens in a slip capital femoral epiphysis? So what actually is a problem? Because once you see a SCFE patient, most often you will see they are obese, they have some pubertal issues, they have delayed secondary characters, and most often it is male. So why it is most often male? Why females are not normally involved? Because the female, I already mentioned, I think maybe that I forgot to tell you, normally it is 3:1 ratio. So 3 males to 1 females, it is not common. So how the incidence of slip capital epiphysis with the sexual the gender orientation. So the male is more involved. So there is a imbalance between growth hormones and sex hormones. So this imbalance weakens the growth plate, rendering it more vulnerable or susceptible to sharing forces of the weight bearing, and even make trivial injury. Maybe they might have some trivial injury which can lead on to a slip capital femoral epiphysis, because this vulnerable zone, this physeal zone is vulnerable because of imbalance between the growth hormones and sex hormones. So why this vulnerability? Why they are susceptible to this injury? Why they slip when there is an imbalance between growth hormones and sex hormones? So I think this is a very very confusing area. So just I want PGs to listen very attentively to this part, because most of the examiners, I'm not sure whether they will be able to give you an exact cause, but they'll ask the question. Even if you don't know the answer, most often will be very fond of asking why there is a imbalance and what the imbalance does to the physis. So normally everybody knows the growth hormone stimulates growth. Okay, so all the growth occurs because of the growth hormone. The growth hormone can act on 2 mechanisms on the physeal area. It acts directly on the resting zone. That's what I told you, because it has got a resting zone and that's 1 second. I'll just see if the cursors. Yeah, it has got a resting zone, it has got a proliferative zone, and it has got a hypertrophic zone. So this area of resting zone, it acts directly and stimulates formation of chondrocytes, and also indirectly it stimulates insulin-like growth factor 1. Especially it stimulates a lot of insulin-like growth factors. The insulin-like growth factor 1 is a very it is highly significant, and this insulin-like growth factors causes clonal expansion of proliferative chondrocytes. I said it is mostly in the hypertrophic zone, but growth hormone acts on the resting zone and the proliferative zone. It normally does not act on the hypertrophic zone. So this is how the proliferative zone also can be taken into account or gets involved in the slip capital femoral epiphysis. So normally the growth hormone is stimulated in a pulsatile manner. Okay, and during the puberty, although because of the stimulation of more amount of sex hormones, these sex hormones stimulate growth hormones. Okay, growth hormone content almost grows 2 to 3 folds during the pubertal area or during the time of the growth. So the sex hormones are very important for growth to occur because they stimulate the growth hormone and starts the growth. Of course, there should be a balance. If the sex hormones are low, then obviously the growth hormones are also going to be low. So what happens, how the sex hormones, how it affects your physis. So what happens is the testosterone is a male hormone, everybody knows that, and estrogen is a female hormone. Normally, males actually do not have estrogen because they have very, very, very minimal content of estrogen. But this testosterone, it gets converted by an enzyme called aromatase enzyme, and they get converted into estrogen. Okay. So suppose the male is a delayed secondary sexual characters. So obviously, he'll have a low amount of testosterone. So this low amount of testosterone will not get converted adequately into estrogen. So even in males, only when the testosterone gets converted into estrogen, this estrogen will stimulate the growth hormone levels. Okay. So directly testosterone does not have that much effect on growth hormone. Only when it gets converted into estrogen, this growth hormone stimulation occurs. And this estrogen will cause skeletal maturation. So it knows it now, your body is got a, see, maybe your genetic, whether you're tall or short, how much you have to grow, how much is physis has to grow. All this is the estrogen only decides. So this estrogen causes the skeletal maturation. So that is very important. If the skeletal maturation is very early, then you'll become too small or too short. The skeletal maturation is going to be very slow, or the physeal closure is going to be very slow because of low estrogen. Then the physis is going to be very weak. So this is what exactly happens. An optimum level of estrogen will cause skeletal maturation, ideal time of skeletal maturation. It closes the physis at an ideal time. So there should be a time when the physis gets closed, and it stimulates the linear growth by stimulating growth hormone. So what happens is, why this estrogen is more associated with slip capital femoral epiphysis. Suppose, as already mentioned, there's a delayed secondary sexual character in male, means the testosterone level is going to be reduced. So this testosterone, when it's very reduced, the amount of estrogen that it gets converted into by this aromatase enzyme is also going to be very low. So because of low estrogen, the physeal closure is also slow. This is not an optimum level of estrogen only allow the physeal closure to go on till an optimal time. So this physeal closure becomes very fast, and so the physeal closure becomes very slow because of low estrogen, and it becomes the physis becomes potentially weak and becomes a wide physis. And there is a skeletal maturation takes a very longer time, like how the secondary sexual character starts appearing. The skeletal maturation also proportionately gets delayed. So this delay in the skeletal maturation causes a potentially weak physis, and this weak physis cannot withstand shear forces, and a slip capital femoral epiphysis occurs. So this is what is the hormonal theory, which I think most of the books do not explain that, because I've taken from a lot of journals and a lot of physiology books. And these secondary sexual characters, when you explain to the examiner, I think if you're able to explain these points, definitely it'll give a lot of value. And this low estrogen, because of low testosterone, cannot withstand shear forces and slip capital femoral epiphysis. Similarly, there is the thyroid hormone. In hypothyroidism, definitely you all know there is a reduced or a stunted growth. So this same phenomenon, what happens in estrogen, the thyroid hormone also does. So the linear growth is reduced when there is a shortage of thyroid hormone. Or in other words, the thyroid hormone stimulates linear growth. It's something like estrogen. There is always a control between the amount of estrogen and the thyroid hormone. There is some feedback mechanism is there, and the skeletal maturation, as like estrogen, on an optimal time will get skeletally mature, and that also facilitates physeal closure. And this thyroid hormone acts like a feedback mechanism. It's called IHH or PTHRH. Don't worry about names. This is called Indian hedgehog and parathormone release hormone feedback mechanism. So this is just don't bother about all these terminologies that I've mentioned. So this facilitates physeal closure by this feedback mechanism, very similar to what acts in estrogen. So when there is a hypothyroid state, obviously the opposite occurs. The skeletal maturation delays, and the physeal closure also gets delayed, and it becomes a potentially weak physis. And why the slip capital femoral epiphysis is associated or is more associated with obesity. So what is the reason? So this is the this is the hormone which is called the leptin. This is also a hormone. It's a protein hormone but secreted from adipocytes. So obviously a obese person will have a lot of adipocytes and lot of leptin will be secreted. So what happens is leptin actually is exactly the opposite of what it does in what the estrogen or the thyroid does. So an increased leptin will act like a low estrogen, and increased leptin will act like a low estrogen, and it predisposes to slip capital because the physis becomes weak when the leptin is there. So the estrogen is very important for skeletal maturation and growth. Testosterone gets converted into estrogen, and thyroid also acts very similarly, especially T3 acts very similar to estrogen. And of course, leptin is exactly the opposite of the estrogen. And this feedback mechanism, or this like a metabolism, or like a vitamin D or calcium metabolism, they act together, and the physis is predetermined. Your growth is predetermined by these hormones. So when there is a problem, the physis becomes weak, and obviously the slip capital femoral epiphysis occurs. So already I mentioned to you the histopathology. So what exactly happens in slip capital femoral epiphysis? So normally the resting zone is more. It is almost 60 to 70%, whereas the hypertrophic zone is around 15 to 30%. But in slip capital femoral epiphysis, the hypertrophic zone becomes 80%. Okay, so this hypertrophic zone becomes 80%. And here you can see the hypertrophic zone, the chondrocytes are arranged in a vertical manner. Okay, so when there is a shear force, because suppose these are the chondrocytes, they are arranged in vertical manner. Suppose there is a slip or shear force going to happen. These chondrocytes, this is the shear force. So these chondrocytes, because they're perpendicular, they will not allow the shearing to occur. But what happens in slip capital femoral epiphysis? Because as I said, all these endocrine factors, all these hormones, the chondrocyte becomes parallel like that. The orientation of the chondrocytes then become parallel. So they are in direction to the shear forces, and the shear force can easily pull out the slip or slip the capital epiphysis. So this is what exactly happens. There is a alteration, or there is a change in the arrangement of the chondrocytes. The physis gets widened, it gets thinned out. Okay, it becomes weak, and the chondrocyte orientation also gets altered into parallelity, and then it easily helps along the direction of the slip. So this is a histological picture. Don't bother too much about this. So already I told you. So what happens is, one, there is decreased number of chondrocytes that I forgot to mention, because as I told you, the chondrocytes get stimulated by the growth hormones. So lower the estrogen, lower the growth hormones, lower the number of chondrocytes. Okay. So, and the matrix is more, and the columnar alignment, which I said, which prevents the shear forces, gets disrupted. And these chondrocytes, whichever the lower amount of chondrocytes also are not very healthy chondrocytes, they degenerate very early. And of course, because the chondrocyte arrangement is not there, this is a potentially weak area, and the slip capital femoral epiphysis occurs. So, and of course, in the early stage of the slip capital femoral epiphysis, the synovium, because there's some kind of irritation in the hip, the synovium will hypertrophy, and there'll be hyperplasia of synovial cells. There'll be villus formation. There'll be definitely some increased vascularity and round cell infiltration. These are only pure pathology. Don't bother too much about this, because definitely they'll have some amount of pain, and the synovium will be in an irritable state. So this is what I mentioned already. I told you, this is a pre-slip state where you can see the chondrocytes very clearly. The chondrocytes are very clearly arranged. Okay, I'm sorry. This is the normal, which is, so you can see the more chondrocytes, you can see thick chondrocytes are seen. Whereas here you can see the number of chondrocytes are getting reduced. The number of chondrocytes on the left is the pre-slip, where the chondrocyte numbers are getting reduced. The matrix is slowly, it is taking over. And here you can see the chondrocyte arrangement is not linear. It has become almost like parallel. And the entire area is, see here it is, the matrix are seen, and the obviously the chondrocyte number also is so much reduced that you can, this becomes a potentially weak area, and the slip occurs. So, and next is after the pathogenesis, next we have to go into the classification, because classification is very simple. There are just, you can take into account 3 types of classification for femoral capital epiphysis, means slip capital epiphysis. It is not as confusing as what it was in avian. It is not as difficult as what it is in avian or Pathis, where you have a capital classification. Here there is got a number of classifications in avian, which Dr. Mageshram had taken. Here it's very simple. The classification can be functional. This was done by a loader. And there are only two in function, whether it is stable or unstable. If the patient is able to bear weight with the slip side, or whether the side where the slip occurs, regardless of duration of symptoms, you can call that stable. Okay. When the patient is not able to bear weight because of slip, you found an X-ray, you found a slip, but the patient is not able to bear weight, then you call it as unstable. So very simple. It is stable or unstable, and this classification is given by loader. And of course, the duration. Duration is acute, chronic, acute, and chronic. The name obviously, explains what the problem is, but just see the duration. It is slightly different from what you normally call as acute or chronic. Anything less than 3 weeks. Okay, the patient has got some amount of hip pain, some groin pain, or a referred pain to the knee, some kind of discomfort has been there. Maybe he's got the features of slip capital epiphysis where he's obese, he's in the adolescent age group. Then suddenly the patient presents to you with a severe pain and not able to walk. That is an acute slip. A chronic slip, patient has got some symptoms for last more than 3 weeks. Okay, then gradual onset. Then they are chronic slip. So most common presentation will be a chronic slip, which is 80 to 85% of the cases that we normally see are only the chronic slips. And acute and chronic, acute, the symptoms are less than 3 weeks. Chronic, the patient has got some amount of vague pain. He's been having it for more than 3 weeks. But one fine day, there was a trivial injury. Okay, it was not a very serious injury. So this is where you differentiate between a type 1 Salter Harris this epiphyseal problem, and then epiphyseal separation, and slip capital femoral epiphysis. Where there in type 1 Salter, there will be a sudden kind of severe injury, maybe a jump, a fall, an RTA, some fall from height, then there'll be severe pain. But here, then previously, they wouldn't have had any complaints at all. Whereas in acute and chronic slip, there would have been some hip problem and one trivial injury. It was not a serious injury, one trivial injury that developed a severe pain in the hip, and that is called as acute on chronic slip. And morphologically, obviously I mentioned it is going to be a mild, moderate, severe, and there is a pre-slip, which is very difficult to explain. You can say there is a pre-slip, but usually what they say is mild, moderate, severe. So the one is a functional classification, other one is the duration, and the other one is a morphological classification, which is mild, moderate, severe. So how do you classify into mild, moderate, severe? So that is how you take into account the Southwick's angle. So here again, I'm telling you, slip capital femoral epiphysis is very, very simple. There aren't many angles for you to draw. The Southwick angle is one important angle. I think that is more than sufficient for you to classify and this slip capital epiphysis. So there are not very many confusing angles, because we know there are so many other confusing angles and so many other conditions in the hip. But here the Southwick angle is one angle. If you know, it's more than enough. So what exactly is Southwick angle? So in AP, you can see the femoral head shaft angle. Okay, it's not a femoral head neck angle. So here is the orientation of the physis. Here you can see. So once the orientation is there, you draw a perpendicular line down, and then you draw a line along the shaft. So this angle, which is a 90-degree subtended from the orientation of the capital epiphysis to the shaft where it meets, this angle in AP view is normally 145 degrees. Okay. Yeah, again, it can be done in lateral view. So lateral view, there are two lateral views, which maybe I'll come to later in when we go to radiography, the radiological thing. So in frog leg lateral view is normally which take the frog leg lateral view. So the frog leg lateral view, which already I told you, is it is 30 to 40 degrees of knee flexion, 45 degrees of abduction of hip. That's all. Where you can take both the hips can be covered in the same picture. So that is normally is the frog leg lateral view. So here in AP view is 145 degrees. Lateral is, again, here I mentioned this is the shaft angle. So this is the orientation of the the capital femoral epiphysis, and the 90-degree angle where it meets the shaft. Okay, that line, that is called as the Southwick angle, which is 10 degree in lateral view. So what happens in this mild? When the displacement is 10, so I told you is 145 degrees. Here it is less than 30 degrees. See, less than 30 degrees of normal. You can take the normal side. Okay, the normal side is 145 degrees. Here it is 120 degrees. So it is 25 degrees lesser than the normal side. So that you can take it as a mild. Okay, and 30 to 60 degrees is moderate, and greater than 60 degrees is severe. So when you don't have a normal or contralateral side, then it becomes slightly difficult. Then you can say it is, no, you can take 145 degrees as a benchmark, or 140 to 150 degrees is a benchmark, and then from there you can reduce. Okay, so that should be not very difficult. So less than 30 degrees, neck is displaced. And in the pre-slip, I forgot to mention about the pre-slip side. So what happens exactly in a pre-slip? So this what exactly in a pre-slip. So here you can see the pictures on the left. So these 4 signs are pre-slip or a mild slip. Okay. The first thing is this I'll come later. I'll come little later when I come to radiology. This is a triangle sign of Kapner or the Schamp sign. So here there is widening of the physis. This physis I already told you. I was mentioning to you. The physis is wider here. Okay. And this you can see the epiphysis. The epiphysis becomes shortened because the head slips backward, okay, or the head slips posteriorly. Then once the head slips posteriorly, then what happens is the epiphysis, which is seen like that, when it comes back, this neck is going to cover the head, or whatever the head has slipped is being covered by the head, and obviously the epiphysis becomes very short. And this is the Trithovan sign or the Klein's line, which again I'll come to you later when we come to the radiology. I'll come. So widening of the physis, there is shortening of the epiphysis. And clinical features, I don't think it's going to be too difficult for you to identify. Because clinical features usually present with pain in the groin, anteromedial aspect of thigh, or a referred pain in the limb on the knee, and usually they present with a limp. And this usually it is a painful limp. Okay, when there's a painless limp, you always think of Pathy's disease. When there is some amount of painful limp, then you can think of, always in this age group, think of painful limp, think of the capital epiphysis. And the pain can be intermittent, can be continuous, and of course, physical activity normally exacerbates the pain. So on examination, obviously, most often, the patient will normally be an obese child. It will be having underdeveloped secondary sexual characters, which you already mentioned, and there is a adipose-genital syndrome. There will be more adipose, more body fat, and less genital development. This adipose, already I told you, secretes a leptin hormone, and this leptin hormone acts exactly on the reverse of estrogen, and is the cause for, I told you, it will secrete increased leptin, it will cause subcapital epiphysis. And here on clinical examination is very simple. There is restriction of flexion, abduction, internal rotation. Okay. So restriction of abduction, internal rotation with true shortening, you can always call it as Coxa-Vara. And we know this is a condition of adolescent Coxa-Vara. So obviously the abduction, internal rotation is restricted. And here flexion is also restricted because the head or the capital femoral epiphysis goes posterior. Okay. So it always goes into extension. So there is an increased extension or a hyperextension. So when compared to the opposite side, if the opposite side is normal, there is definitely an increased extension. There is shortening with external rotation because the head again goes posterior and inferior. And already I told you the shaft rotates externally. So there the attitude of the limb will be in external rotation. The gait is a typical Trendelenburg gait, will definitely be seen, or if the patient has got a pain, he will present to you with an antalgic gait. Okay. So, and the characteristic of all stripped capital femoral epiphysis, which you know, is axis deviation. Axis deviation, which we all know, is when you flex the hip, it always moves towards the opposite shoulder. But when during an externally rotated limb, what happens is, because the internal rotation is restricted, the limb goes towards the same shoulder. So axis deviation is one thing which everybody has to demonstrate. Definitely they will ask you to demonstrate axis deviation. It's very simple. So axis deviation, as we demonstrated, there is hyperextension. And obviously there is restriction of abduction and internal rotation. And the contralateral exam hip, always you examine the contralateral hip and compare always with the opposite side. So here you can see the adiposogenital syndrome. The secondary sexual characters are underdeveloped and the body fat is very high. The limb is externally rotated. Here you can see this limb is, externally rotated here, and it's obviously shortened also. There is restricted of internal rotation. Internal rotation will definitely be restricted. See, this is the limb. This is the opposite limb where the internal rotation can be very obviously seen, but here you're not able to bring it into internal rotation. So restriction of, and abduction also gets restricted. So abduction, internal rotation, shortening, there is hyperextension, there is axis deviation. Okay. So all these things are, and restricted flexion. So all these things are the clinical features that we have to mention when you present the case of flipped capital femoral epiphysis. So here you can see, this I got it from one of my friends, this photo. So here you can obviously see the limb is going in for external rotation. So this is axis deviation, where it is supposed to go towards the opposite shoulder. The hip is supposed to go towards this shoulder, but it is going exactly towards the same side. Okay. So imaging, when you come to imaging, obviously, as an orthopedician, X-ray is the most important. And X-ray is more than sufficient to diagnose flipped capital epiphysis. Okay. So X-ray already mentioned, there is AP view, there is a flogged lateral view, and there is a modified Billings view. Modified Billing view is again a lateral view with some alterations. So modified Billing view is usually there is an AP projection, but lateral view. So 90 degrees flexion and 65 degrees abduction. Okay. And neutral rotation of the hip. But few books, this is the Journal of Pediatric Orthopedic from where it is taken, but few books say otherwise. So what I will mention is go and just take a reference of modified Billings lateral view. I've taken a lot of reference and a lot of different things that have been mentioned in different books. So usually what happens, the limb is 90 degrees flexed. Okay. The knee is 90 degrees flexed and the limb is kept slightly external rotated with a support. So obviously what happens is the soft tissue penetration component is very, very low in a modified Billings view, and you can get a very exact picture of the lateral view. And this lateral view can give you an idea as to how much the capital epiphysis has slipped. And also post-operatively, when you do a screw fixation or a pin fixation, it gives a clear idea whether the screw has penetrated the joint. I think this view is a very, very, very significant or very helpful in post-operative cases to find out exactly the level of screw penetration. So obviously I told you. So how to differentiate acute slip, chronic slip, and acute on chronic slip. Okay. So the AP view and lateral view I mentioned. Frog lateral view I forgot to mention. Frog lateral view also already told. You can take both hips at the same time. It is very reliable in slip capital femoral epiphysis. You have to keep the knee in 30 to 40 degrees of flexion and the hip in 45 degrees abduction. Okay, that is exactly the position of how the frog lies. So in acute slip, how to differentiate by X-ray whether it is an acute slip, whether it is a chronic slip or an acute on chronic slip. So acute slip happens suddenly, less than 3 weeks. So there's no question of any remodeling. It is something like a fracture and a non-union. Okay, just imagine there's a fracture and a non-union. See, obviously, when the fracture happens, when you see an X-ray in a fracture, there are some serrations. Okay, these ends are not very smooth. Whereas in non-union, you can see the ends are smooth. The serrations are not there. Okay, so similarly, remodeling in X-rays has got certain appearance, which obviously, as an orthopedician, everybody is going to learn that. So this remodeling will not be there in an acute slip. Okay, whereas in a chronic slip, there will be a remodeling. So once the head slips out, what happens is that area starts throwing a lot of callus. Okay, the periosteum or the periosteum at that level, or the capsule at that level gets torn. The perichondrial ring, I told you, gets torn, and that area starts forming callus from that area. And this callus forms something like called a hump. And if it's going to be long time, definitely it forms a huge hump. And this remodeling at the level of the femoral neck, especially the anterior superior aspect of the femoral neck, will be very, very obvious. It forms a hump appearance. Whereas in acute on chronic, there will be both findings. Okay, there will be some amount of remodeling will be there, but the slip, see what happens is, so suppose the head slips out. This area between the head and the area of slip, the remodeling will be there fully. Whereas in acute and chronic slip, that head slips more than the area of remodeling. Okay, So this you can see, the hump you can see is very clear. It's the Hemden's hump. Okay, so it's called as a Hemden's hump. Hemden's hump. It's Hemden's hump. So this hump is very clearly seen, and this till this area of remodeling you can see the head. Whereas in acute or chronic, this what happens is this head slips further down, and this area there will not be any remodeling. So that I know it is a little subtle. Don't bother about it too much. Okay, in the exam, if they ask you, you must be able to tell them that the remodeling is seen in a chronic. It is not seen in acute, and some amount of remodeling can be seen on a acute or chronic. And already I mentioned this is another important X-ray. Is this seen in the AP view? This earliest radiological sign. Of course, the widening and irregularity of the physis is the earliest sign of pre-slip. And the Klein's line again. See what happens is, I think this almost everybody knows. A line is drawn parallel to the superior aspect of the neck. So normally what happens is some amount of head will be outside this line. Okay, this is normal. Whereas when this head is going to slip down like that, this line, the head goes beyond this line. So this is called as a Klein's line, and the sign is called as a Trithovan sign. The line intersects a small portion of the superior aspect of the neck, of the head. When it slips posteriorly, this line will not intersect the head and it will lie outside. The head will completely lie outside the head. So this is called as the Trithovan sign. There are only 3 X-ray findings. If you remember these 3 findings, that is again more than sufficient. Trithovan sign, the metaphyseal blanch sign of steel. So what happens is the head is going to go posterior. The head is slipping out posteriorly. So posterior to this neck, you have a head. So when you take an AP view X-ray, this area, because the head is there posteriorly, this area will be have a different or a hyperdensity, not normally double density. Don't worry about double density. This area will be hyperdense because of the head which is posterior to the neck. So this is called as the metaphyseal blanch sign of steel. Okay, so because there is a blanching or a hyperdensity is seen, so it's called as a metaphyseal blanch sign of steel. And next sign is the triangle sign of Schamp. Already I told you. So this is the normal side. So what happens is the superior portion of the, or you can say the inferior portion of the head, and this area of neck normally lies within the acetabulum. It lies within the joint. But what happens here, you can see, when the head slips posteriorly and inferiorly, this area is pushed down, and this area, or the triangle area, which is normally seen in the superior aspect of the neck, which is inside the acetabulum, now moves out. So this triangle area is outside the joint, and this is called as a triangle sign of Schamp. So these 3 signs, the triangle sign of Schamp, the metaphyseal blanch sign of steel, and Trithovan sign, are the 3 important X-ray findings in slip capital epiphysis, which is more than enough if you know. Of course, this ultrasound also gives some value, definitely of theoretical value. I don't know how many of us perform an ultrasound on these patients. As I told you, the metaphyseal remodeling is seen sometimes. Okay, so the absence of metaphyseal remodeling means there is an acute the episode is little acute, and they can be classified as unstable. Okay, so when the metaphyseal remodeling and when there's an absence of effusion, there is no effusion, of course, and then there is remodeling is also there, then you can consider that as a stable. So, and in ultrasound, if the displacement is more than 6 mm, or the capital epiphysis is slipped more than 6 mm from the neck, or it is 2 mm more than compared to the opposite side, then you can diagnose a slip capital epiphysis. You can still do that. Okay, without X-ray also you can do that, but I think we are more comfortable with X-rays. And what is the importance of CT scan? Of course, CT scan has definitely has got some role in slip capital epiphysis. So it's got a role in diagnosis, it's got a role in management, and it's got a role post-treatment or post-surgery. So you clearly see here, you can see where we saw a head and shaft angle. Here you can see a head. Here this head shaft angle can be clearly seen in CT scan. Okay, this can be, see, this is the normal shaft angle actually, if it has to be correct. But here it is clearly outside. This is the head shaft angle. where the head has to be like this. The head has to be like that, but now it is tilted down, and the shaft angle is completely altered here. And this can be, of course, used for documentation to say the slip capital epiphysis in CT scan, and of course to confirm your diagnosis whether the physis is closed. So when you do an osteotomy, there are different osteotomies which should not be done when the physis is closed, and a few osteotomies should be done only when the physis is open, and few should be done when the physis is closed. So this helps you give a kind of an idea whether the physis is closed and what kind of osteotomies can be performed. Okay, and of course in treatment part, also already told you, see whether the screw is penetrating the hip joint, because screw penetration is a very crucial factor which should never happen, because if it does, then the idiopathic the chondrolysis, which is a very severe complication of slip capital epiphysis, can easily occur. So this is about CT scan. And of course, all this chondrolysis can be seen in technetium uptake, and avian and chondrolysis are two common complications of slip capital femoral epiphysis, which can be diagnosed easily by a technetium 99 scan or a MRI. So these are a few differential diagnoses. So in our population, TB arthritis, of course, is a very common one. So always keep in mind TB arthritis when it is unilateral. If it is going to be a bilateral, it's not TB arthritis, very unlikely. And of course, there is no hyperextension TB arthritis. The joint will be in, definitely will be in fixed flexion deformity, will definitely be there. But TB arthritis, do consider, just keep in mind whether it could be TB arthritis. And of course, Perthes disease, already we've so many times it's been speaking about the differences clinically between Perthes disease and slip capital epiphysis. And of course, a type 1 epiphyseal fracture, which already I mentioned, the Salter type 1. But here it occurs, the slip occurs at the level of the metaphyseal level, but there it occurs at the level of the epiphyseal end. And it will be very severe, the pain will be very severe, the patient will not have any prodromal symptoms. It will be a sudden injury without any previous history of any groin pain or hip pain. So I think that completes the etiopathogenesis, the clinical features, and the radiological findings. And I think it's difficult to, you have to diagnose as Cox-Savara. Okay, so age group of course matters. Usually in Perthes disease, the age group will be around 7 years or less than 10 years. You can take that less than 10 years. Whereas slip capital femoral epiphysis very rarely will present in the first decade, because if it is going to be a hormonal problem, okay, a very severe endocrine issue, a chronic renal failure where there's hyperparathyroidism, then they can present before 10 years of age, which is very, very rare and it's very easy to pick up also. And so this is about the age group. And here what happens is in Perthes disease, again there is restriction of abduction internal rotation, but there is always a flexion deformity. Whereas in slip capital femoral epiphysis, there's always a extension deformity. Whereas there is a hyperextension or more than normal, because that is how the slip goes, because it goes posterior. Obviously, the head also is going to be posterior. So there is a hyperextension, and both are abduction external rotation is, abduction internal rotation restricted, but here it is more in external rotation. The slip capital femoral epiphysis, the external rotation is more, and always there is an axis deviation. In Perthes disease, if the head is flattened or the head is destroyed, okay, most often that will not happen. If the head is destroyed, and once that also goes to for a fixed external rotation, then obviously the axis deviation will be there in Perthes also, and the shortening will be more in Perthes disease. Okay, whereas it will be comparatively it will be lesser in slip capital femoral epiphysis. And the secondary sexual characters, delayed secondary sexual characters can be very obviously seen in, and the body habitus and obesity can be seen in slip capital femoral epiphysis, whereas in Perthes, usually they are short statured, they are thin built, and they might have a sibling also who is short. If they have the siblings, the younger ones will be taller than the affected ones. So this is about the clinical differences.
And that this joystick sign.
Yeah, joystick sign.
Gear stick,
gear stick sign, which is in Perthes disease, where when you flex the hip and then you abduct. Okay, normally the abduction is restricted, whereas when you flex the hip and you abduct, the abduction will be more in Perthes disease comparatively when it is in extension. So flexion and the abduction and the flexed hip is more, whereas here there is no such. I don't think there is anything like gear stick sign in slip capital femoral epiphysis.
And in Perthes there is a painless limb. Here
that I mentioned already. Yeah, then usually there is a painless limb. Here it is a painful limb. Yes.
And regarding that Billings, modified Billings,
yeah. So a lot of confusion. That
actually abduction is restricted in this condition.
Yeah. So what happens
And
is
Billings requires a 65-degree of abduction.
Illa. That's
So
what
I think
that's what I'm told. The slide I have not changed the slide, but recently I looked into the Billings. So Billings, what happens is because what happens is there is 90 degrees of flexion. You keep the limit 90 degree knee flexion, not hip flexion. I'm telling you, 90 degrees of knee flexion. You flex the limb, flex the hip as much as possible, and you keep in only 25 degrees abduction. Okay. So when there's 25 degrees abduction, you keep a support underneath the abducted limb, and you rotate the table. You don't usually abduct the hip. What you do is you rotate the table, okay? By giving a support, you slightly rotate the person, or the pelvis is rotated, and then taken to 65 degree and the X-ray is taken. So finally what happens, it looks like a 65 degree abduction, but the rotation of the person itself, the pelvis itself gets rotated here. That's what they say in Billings, because I read the article also, it is 1954. This article, I got a download of the article also. It is mentioned by Billing in 1954. He has taken to see whether the opposite hip will be involved or not. So Billing, and when we first wrote this article, it was not for treatment part. He wanted to find out that how many opposite or the contralateral hip, what will be the involvement of the contralateral hip in slip capital epiphysis. That is what Billing has done to see the opposite hip by taking this view. He has written, he's taken around 80 cases, and then from that he has found out that around the percentage of involvement will be like this, based on the Billings X-ray, Billings view. So, any other questions? You are welcome to ask. So I think this endocrine concept, I think everybody needs to understand a bit. I know it's a little complicated. It's not given in any book. Okay. Even the physiology books are not very clear about this, because I took a lot of references and went through a lot of references to bring out the role of estrogen, which is more important in closure. That is why in female gender, the estrogen is sufficient for them to get the physis closed at an optimum time.
Good evening, sir. Manoj.
Sir. Yes, ma'am.
Sir, just 3 points to add, sir. There's a SCFE in solita we are telling, sir. It can also be called as SUFI, sir, upper femoral epiphysis.
Yes.
So that they won't forget the femoral neck is getting displaced rather than the epiphysis.
True.
They can easily remember it.
Yes, true. Yeah.
Second one, sir, bilateral hip usually the opposite hip which is getting involved is called as the pre-slip in solvona, sir. So
that's what I'm telling you. Pre-slip is always, the pre-slip is there. Something like a stage 0 in avian. Okay, the opposite hip is stage 0. The opposite can be always considered as pre-slip. But not normally all the hips will slip. If it is an endocrine cause, it will definitely slip. Okay. But other than that, when it's an idiopathic, we're not able to identify an endocrine cause, the slip percentage is very, very low. Okay. So not always by all the hips are bilateral. So don't ever think that if you have one side, you'll have the other side also getting slipped. It's not like that. So that is why there is always a controversy in fixing the opposite hip. So when there is a normal contralateral side, you would want to do a pinning, okay, of the contralateral side. So what cases you select, your case selection for your contralateral hip is always a controversy. So prophylactic pinning is a short note for postgraduates. Again, so prophylactic pinning will definitely come. So I think we'll come to treatment part, we'll mention about it. Manoj, third point, you wanted to say some third point.
Yes, sir. And the axis deviation can be remembered as knee axilla sign, sir. So that அவங்க டெஸ்ட் பண்ணும்போது knee going to the ipsilateral axilla அப்படி ஈஸியா ரிமெம்பர் பண்ணிக்கலாம்ன்றது.
Yeah, correct. Yeah, SUFI is also well taken. Yes, definitely. SCFE SCFE போட்டுட்டால் எனக்கு somewhere from earlier time we've been reading SCFE is very difficult for me to change. Bombay, Mumbai mari adu. So people can take it as Mumbai, you can take it as Bombay. So whichever you're comfortable, you can do that.
That's all, sir. Thank you, sir.
Yeah. Thanks, man.
Sir?
Yeah.
Knee axilla sign means normally the knee will
go to the opposite axilla.
So this knee axilla sign is negative.
Negative. Knee axilla does not go to the opposite axilla, it goes to the ipsilateral axilla.
Okay.
So knee axilla sign is
knee
mentioned
axilla
lot of
sign
books.
is positive. Knee
Positive,
axilla sign
positive.
is positive.
Positive. Knee goes to the same axilla. So it is positive.
Instead of opposite.
Yeah, instead of opposite, it goes to the same axilla.
Sir, one more thing, sir.
Yeah.
So in your talk, you are telling about the slipping occurs at the head. But most of the texts tell the slip occurs only at the femoral neck. That is, femoral neck and shaft is moving anterolateral, and the head remains in the same.
No, I think you joined a little late. That's what I told. Nee sonna adhe same point only I told. See, this is a misnomer. It is a misnomer. Slip capital femoral is a misnomer. Okay, that was my third slide. So normally the shaft rotates externally with its neck. Okay, and pushes the head posteriorly and inferior. So obviously the head is in the acetabulum. That's why I'm telling you. If it's going to slip outside, then it will go outside the acetabulum. Okay, but here it is inside the acetabulum itself. So here it is a misnomer. That's what I told you. Yeah. So I know it's not a very tough topic. It's pretty easy. Go and read all these things because these are certain things which are not given in all the books. So any other doubt, Choran, Edwin?
Sir, good evening, sir. Prabhu, sir.
Prabhu, solluma.
Sir, இப்போ chronic SCFE அந்த remodelingனா அது எப்படி சார் என்ன சார் தெரியும் remodeling என்ன மாதிரி
இப்போ it's something like a callus ma. See, when you see a fracture, a fresh fracture க்கும் old fracture எப்படி 1 month old fracture எப்படி டிஃபரன்ஸ் கண்டுபிடிக்கிற?
அந்த ஸ்க்லீரோசிஸ் ஆயிருக்கும் சார்.
ஸ்க்லீரோசிஸ் இல்ல. See, அந்த bone வந்து ஷார்ப் ஒரு மாதிரி ஷார்ப்பா ஒரு மாதிரி வந்து it will have serrations and all that will become little smoothened. புரியுதா? There will be some amount of smoothening of the full curve ஆயிராது. There will be some amount of smoothening will be there. The serrations will be lost. Okay, the ends will become slightly rounded. There will be some amount of callus which is getting formed. Okay, there will be interposition of some அதாவது ரொம்ப கம்ப்ளீட்டா இது தனியாவும் இது நெக் தனியாவும் இருக்காது. Okay, it will not be completely separate out. There will be some amount of calcification, some amount of opacity between the two areas. Okay. Whereas in acute there will be obviously it will be completely outside. ஒண்ணுமே சம்பந்தமே இருக்காது ரெண்டுத்துக்குமே. இது தனியா இருக்கும் அது தனியா இருக்கும்.
ஓகே. இப்போ மெட்டாஃபிசியல் பிளான்ச் ஸ்டெயின் அது வந்து என்ன ஃபேஸ்ல இருக்கும்? அக்யூட்ல இருக்குமா கிரானிக்ல இருக்குமா சார்?
இல்லப்பா இதெல்லாம் chronic only. It is chronic only. Acute la we don't mention about all these metaphyseal sign and all. See, 85% of the time or acute and chronic it will be there.
Okay.
Acute and chronic will be there.
மெட்டாஃபிசியல் பிளான்ச் ஸ்டெயினும் அந்த ரீமாடலிங்கும் ஒரே மாதிரி தானே சார் இருக்கும்?
No. See, remodeling is the Hemden's hump I told you. Okay வா? ஹெட் வந்து வெளியில வந்துருது இப்படி. அப்ப இந்த ஏரியா இருக்குல்ல இந்த ஏரியால ஃபார்ம் ஆர் கேலஸ் தான் வந்து ஹம்ப் ஆர் ரீமாடலிங். பட் இப்படி நெக் இப்படி இருக்கு இந்த ஹெட் வந்து பின்னாடி போயிடுது. ஓகே, இட்ஸ் கோயிங் பேக் லைக் தட். சோ எக்ஸ்ரே எடுக்கும்போது என்ன ஆகும் உனக்கு?
அந்த ஓவர்லாப் ஆயிருக்கும்.
நெக்கினுடைய ஒபேசிட்டியும் தெரியும். ஹெட் பின்னாடி இருக்குல்ல அதுவும் வந்து கால்சிஃபைட் ஏரியா தானே. சோ ரெண்டு ஒன்னோட ஒன்னு சேரும்போது it will be like a double opacity. So that will look like a blanch sign of a steel. That's called as a blanch sign of steel.
Okay, sir. Yeah. Thank you, sir.
Other institutions also you are welcome to ask because don't feel anything like this. So if you want to ask any doubts, even other institutions, you are welcome to ask.
Hello, sir.
Yeah. Sollu Venkatesh sollu voice தெரியுது.
Sir, ஒண்ணே இல்ல sir. Sir, just what are the important history and general examinations to be seen during examination, sir?
Yeah. See, yes.
In particularly in the case of SCFE, sir.
See, obviously I'm கொடுத்துருவான்ப்பா. When you see a patient, okay, it's not going to be very difficult for you to ask. So what you do is axillary hair examine பண்ணனும். Okay, secondary sexual characters, perineal regions you have to examine. Okay, but you have to be very careful. So you have to take the permission. There will be small penile areas. The penis will be very small. Okay, there will be a lot of fat around that area. The pubic hair will be low. Okay, the axillary hair will be underdeveloped. So there will be thick. The patient will be very obese. Okay, they will be having a gynecomastia. So all these things are general examination you can easily find out. Okay, இது ஈஸியா கண்டுபிடிச்சிடலாம் general examination. History is not very difficult. History வந்து see our development history கேளு. Okay, whether they are on some other treatment for some hormonal deficiency or thyroid problem இருக்கா, all these things that you can ask in history. And other than history, in the history தவிர I don't think there's anything very significant I don't think there's much significance in history because it will be very obvious. பார்த்தாலே தெரிஞ்சிரும் உனக்கு. அவனை சொல்லுவான், சரி எனக்கு ஒரு பெயின் இருந்துச்சு சார், ஒரு 3 weeks 4 weeks எனக்கு 1 month பெயின் இருந்துச்சு, அப்புறம் சரியாயிடுச்சு. திடீர்னு இப்போ வந்து லைட்டா திரும்பி தடுக்கி விழுந்த உடனே எனக்கு திரும்பி வந்து பெயின் இப்போ அதிகமாயிடுச்சு. That means it is a acute on chronic. A chronic one is slowly they keep on developing some kind of pain. Okay, some nagging pain is there always for them. They're not comfortable. So most often they will come with some pains, they'll come with limp, they'll have severe external rotation deformity, so they'll not be able to internally rotate. Okay, so internal rotation will be a problem. So அதுக்கு தனி osteotomies-லாம் இருக்கு. So அந்த மாதிரி condition they'll come. So for internal rotation difficulty, they'll not be able to squat properly. So all these things will come in history. So history is not very difficult. General examination also is not very difficult. So make sure that you check the secondary sexual characters. Because slip abdominal epiphysis, if you're not going to check the secondary sexual characters, then you might fail. So you take the permission of the parent, okay, take the consent of the person, and make sure that it is done in a very decent way. Okay, secondary sexual characters you just cannot, go and without the consent of the person, don't do that. So that again will give you a problem. So you make sure that all these things are strictly followed.
Hello, sir.
Yeah, brother, சொல்லுமா.
Sir, இப்போ pre-slip ன்றது வந்து incidental finding as well as symptomatic finding.
Pre-slip normally will not have symptoms. That's what I'm telling you. Pre-slip is normally not a symptom. See, that's what Manoj said. So when you examine a patient for a slip abdominal epiphysis, obviously you're going to take an X-ray. Okay. So X-ray la opposite side எடுக்க போறோம். So you're going to have a comparison between the normal side or the so-called normal side and the affected side. So in the normal side எடுக்கும்போது, when you see certain signs, this Klein sign, the widening of physis, okay, there is the epiphysis is short.
Okay.
இதெல்லாம் நீ பார்த்த அப்படின்னா அந்த triangle sign of sham நானே பார்த்தது இல்லப்பா. It's all theoretical. Okay. I've never looked into a triangle sign of sham and all. Okay.
இல்ல சார், நம்ம pre-slipல வந்து நம்ம வந்து just widening and irregularity மட்டும் தான் நம்ம சொல்றோம்.
Widening, irregularity of physis, definitely the epiphysis will be short. It might be short. Okay. So some slip is there, so it might be short. Klein's line, of course. Klein's line definitely போட்டு பார்க்கணும்ல.
Okay. Okay sir.
அப்புறம் Southwick angle போட்டு பாரு. You can also always put a Southwick angle also. Take a frog lateral view and always put a Southwick angle for in both AP view and lateral view. So all these things you just try to if you know all these points. So 5-6 point உனக்கு தெரியும் இப்ப pre-slip னா என்ன பண்ணலாம்னு. Now you go and look at the patient. Now you go and see an X-ray of slip abdominal femoral epiphysis. You have some X-ray in your with you in college or இப்போ X-ray எடுத்து போட்டு பாரு. Now you go and see. Now your orientation may be slightly different.
Okay sir. Sir, அவங்களுக்கு நம்ம என்ன அட்வைஸ் கொடுக்கணும் சார் from preventing them from pre-slip to slip?
See, patient obviously has to be given rest. It has to be followed up. Patient has to be followed up. You always give them an option of the treatment part. I'm going to come. So you always give them an option of prophylactic pinning, or you can wait. There are a lot of controversies. There are a lot of differences of opinion. It depends. And the treatment part, I think, will come tomorrow. நீ என்ன பண்ணலாம், அந்த pre-slipக்கு என்ன பண்ணலாம்ன்றது maybe அது ரொம்ப பெரிய, it's not a very complicated thing. Either you have to pin or you don't have to pin. That's all.
Okay.
Pin பண்ணலனா அவனை கேர்ஃபுல்லா பாத்துக்க சொல்லுவேன். திடீர்னு அவனுக்கு பெயின் கொஞ்சம் அதிகமாயிடுச்சுனா you have to ask him to come to you. Okay. So till the physis fuses. So once your physis is fused, once the growth is complete, it's not going to slip. So till that time you have to be little careful. If you're not going to pin it, till that time you have to be little careful.
Okay sir. Thank you sir.
I'm not sure if there are any. So I think the hormonal things, all these things are little complicated things which not given in books. So I wanted to mention little detail. So treatment part again I will come back later, and there is a separate session for osteotomies around hip.
Sir, even though with crutches, when he is able to weight bear, it is called stable. அப்படினு
சொல்லலாம்.
Or
if he is able
unstable
to weight bear,
sir, if he is limping with crutches nalum it is stable as sir.
Stable அப்படினா he is able to bear weight. புரியுதா? crutches இருந்தாலும் அது it's a difficult one to explain, but I think book says that even with crutches, if they are able to bear weight, I think it is stable only. If he is able to bear weight with crutches, it is stable.
Okay.
If he is not able to bear weight even with crutches, then you call it unstable. எக்ஸாம்ல நான் கேட்குற கேள்விக்கெல்லாம் உன்னால பதில் சொல்ல முடியுது, வித் என்னோட கொஞ்சம் சப்போர்ட் இருக்குது, பக்கத்துல ஒரு எக்ஸாம்ல உனக்கு சப்போர்ட் பண்றாரு அப்படின்னா நீ ஸ்டேபிளா இருக்கிறன்னு அர்த்தம். உனக்கு வந்து நீயும் எக்ஸாம்ல ஆன்சர் பண்ண மாட்டேங்கிற, நான் கொடுக்குற க்ளூவையோ இல்ல உன்னோட இன்டர்னல் எக்ஸாம் கொடுக்குற க்ளூவையோ சப்போர்ட்டையோ உன்னால எடுத்துக்க முடியலன்னு வச்சுக்கோ, தென் யூ ஆர் டோட்டலி அன்ஸ்டேபிள் அர்த்தம். சரியா? So it's that. Anyway, I'll just refer that tomorrow. It's a good question. நான் திரும்பி பார்க்கறேன் நான். Whether with crutches you can call it stable or unstable. That is your question, right?
Yes, sir.
Yeah, to my knowledge, even with crutches, if he's able to bear weight, you can take it as stable. But anyway, we'll confirm it tomorrow.